volume within women's and children's. So the model of going to an LDRP would be to combine physically the labor and delivery department and staff with postpartum couplet newborn care. And so that is where, instead of staffing two separate individual departments, it would be combined, which would provide for a variety of efficiencies.
Okay, let me ask you this. Can you do that whether or not you shut down 5 licensed pediatric beds?
But you still have to have staffing that can manage labor and delivery and postpartum couplet care. That would require to also have pediatric care, which we can't always cover. And when we have such low volume, and it's most of the year, there's no one in those beds to staff it, becomes very challenging.
Okay. All right. I think any clarity that you can provide in follow-up would be really helpful as we think about the PEDS unit on its own and what you're planning to do afterwards in the new redesign. Trying to understand the savings independently. It's just a bit confusing. I will just say that as I'm listening to you and as I listen to my colleagues' questions, it's a bit still confusing, but perhaps I have to go back and look at your narrative, and anything follow-up that you can provide would be helpful. Let me just go through some of my other questions. Okay, so I did just want to talk a bit about access and how did you assess the accessibility of UVM and Dartmouth-Hitchcock as alternative sites of care? And by this, I mean, do you assess, do you have the occupancy rates, the transfer acceptance rates, how often they're at capacity? Do you have a sense of that?
Yes, so I'll take
Actually,
that
do you have
question.
data on that?
Yes, so this is Judy Fox. Again, we have to be very careful on what we can and can't share due to antitrust, but I did have multiple conversations with Dr. Stephen Leffler, as did Dr. Davis have questions with Dr. Bell at UVM. And my conversations were around the fact that according to Dr. Leffler, their general pediatric unit has capacity. In full disclosure, the unit that is challenged with access is their NICU unit. Those patients are not part of this scenario here, because we would have transferred them anyway. And so as we considered what the opportunities were and constraints within capacity for the system, I certainly did have that conversation with UVM.
Yeah, I think the struggle for me is, the application or your notification claims the formal transfer agreement with UVMMC ensures timely coordinated access to tertiary level pediatric care, but the transfer agreement itself actually emphasizes in bold that UVM is not obligated to accept a patient if it doesn't have capacity. So it's not clear to me that the transfer agreement ensures timely access to care.
Yeah, so that is really looking at their capacity and having conversations with their leaders in their organization.
Yeah, and I guess I would ask too, the comment was it ensures access to tertiary level pediatric care. What if the level of care is not tertiary level? It's non-emergent, non-critical, but it's not appropriate for an ED.
Yeah, so that's where I'll let ED partners, Sheena and Dr. Davis, have a conversation around that, because they've been integral to those discussions.
Yeah, this is Sheena Fisher, nursing director over the emergency department. I just wanted to go back to your question around transfer. So as I'm
Mhm.
sure you're aware, there's a daily pulse check that occurs between all regional hospitals, Vermont, and UVM Health Network, to include Dartmouth, every day at 10 a.m., which Rutland Regional Medical Center participates in, at which time we discuss current census, capacity, and transfer acceptance. During this conversation, we review pediatric admission opportunities at tertiary care centers. As you know, CVMC doesn't admit peds either, and this is a conversation that we discuss daily. I don't have the percentage of time that they are at capacity. I've been doing this meeting for Rutland Regional since March, and there was one day in September that UVM peds was on a red status, which was a general like high census, high capacity. As far as our ability to transfer to non-tertiary care centers for pediatrics, that's just not something that we have done because there are so few hospitals that our patient population wants to be transferred to that meets the needs of those patients.
Yeah, and again, I would say that under EMTALA, if there is a patient requiring hospital admission, and that's not a service that we provide at our hospital, and there is capacity at another hospital, generally speaking, those are academic medical centers, there is an obligation to accept the patient. So I think if we don't have an inpatient unit and a child needs inpatient care, whether or not they're requiring, a specific subspecialty at the tertiary care hospital, if they're requiring a hospitalist level of care, the same way that Porter Hospital or CVMC would transfer to UVM, we would be transferring also.
Okay. What is the difference in cost per day at Rutland inpatient versus Dartmouth Hitchcock versus UVM for the average commercial patient?
I have the room charge. This is Jen Bertrand. I have the room charge difference between UVM and our room charge for the inpatient pediatric unit. Our room charge is about $2,000 per day, and UVM's is $3,400 per day. I do not know Dartmouth Hitchcock's off the top of my head. I did not look at that one yet.
Okay. That would be helpful, and also seems important to understand if you're doing a total cost of care calculation. I think I'm just looking at my stuff. I think that's it. Chair Foster, back to you, I think. Thank you very much for answering the questions.
Sure. Dr. Merring, go ahead if you have something.
Just a couple quick follow-ups. If you're doing the room charge, can you do I think you could see it in the price transparency files, what's actually paid. If your room charge is $2,000 a day and you've got, I don't remember what your total number of patient days for the year is, but probably it'd be like, what, about 325 or 350 days for pediatrics, but you're getting $700 in admission on average. You're not getting the charge. So I think that would be helpful to understand what's actually paid. And that could be probably found through the price transparency files. I just want to talk a little bit about the example of the pediatric IV. Just an anecdote. I mean, my understanding is that the UVM inpatient pediatrics floor does not place their own IVs either, and has an IVT team come. And I would just sort of note that from my view of the world, and maybe they're not quite the pudgiest arms, but quite scary to me, are IVs on those under 30-day-olds, which are still being admitted. So I guess that example of a skill that's waning among the pediatric care team there, I don't know if that's unique to Rutland. That seems to also occur at academic medical centers where IVs are not commonly placed on the floor and need IV teams to come up. I don't know if there's other examples that you want to provide. that are
Sure. So
more
I
relevant.
I was trying to provide you with a recent example that was shared with me. And I am also familiar with academic medical centers having IV teams. But a hospital of our size, we're not, really equipped to stand up an IV team right now. But so with that said, we're really nervous with the decrease in pediatric volumes and the projection to continue to decrease, that the ability for our teams to care for those patients is going to be harder. And with our ED seeing so many patients on a daily basis, they're able to keep up those clinical competencies. And so that's where we're hoping to focus that care. The vast majority of our patients, like we've shared, stay for less than 24 hours. And so being treated in the emergency department is an appropriate place for most of them.
Maybe just one other follow-up question. I just want to clarify one thing that was discussed, and maybe I misunderstood it, but did you say that in part of this whole redesign effort, you're changing there was something about how like labor and delivery is in one place, but labor and delivery is in one place, and then postpartum care is another place, and you're changing the orientation of those, or are you I understand you're doing some work to remodel labor and delivery. Is that coming? Is that something that's in the works?
So we are working towards a labor delivery postpartum recovery model. Other hospitals in the region use the same type of model. So it's staffed with labor and delivery nurses who have the competency to care for that patient population, including newborns up to that 28 to 30 day age range. And so that's the model that we are moving toward to provide that care and that setup here at our RMC.
So is that sort of what's driving breaking off the PD, is that you're now changing the model of labor and delivery so that you can use this shared nursing and physical space capacity, and then this pediatric room's physical space no longer fits into that physical space?
So it's a combination of factors, but when we look at our data to see that over 90% fell in that low to low acuity with that short length of stay, it really doesn't justify the need for inpatient pediatric beds that are largely unused and could still be cared for, but in a different setting. So a combination of factors.
Are you changing the physical plant of your labor and delivery postpartum care units?
We're working to combine physically so that they're in one location. Yes.
Okay. Would it be possible for you to just provide, not a super detailed sketch of the current system, the current layout, and then your future layout, just so I can wrap my head around on what we're talking about?
I'm sure we could provide something.
Thank you. Thanks.
Okay. We're a little over, so actually quite a bit, but I really appreciate the board members' questions. That was really helpful, and I appreciate the answers. I'll try and be quick. When did Rutland begin evaluating this potential change?
Yeah, so I'll take that question. This is Judy Fox. We began this evaluation mid-summer as we were trying to understand how we were going to respond to significant changes in reimbursement.
And Ms. Fox, was that before the budget submission or after to the care board?
Yeah, this was after the budget submission and working with our board of directors on the fact that we were budgeting a loss as a result of changes in reimbursement.
Okay. And are the changes in reimbursement you're speaking to, are they related to the Act 55 changes in outpatient drug prices?
Primarily, that is one. But we're also looking at, Act 68 and reduction of expenses and regionalization of services. So we were trying to find a way that we could plan for numerous changes that we felt were coming in.
Okay. So is it fair to say that this change would help ameliorate some of the planned operating margin losses that were submitted in the budget?
That is, yes, that you can make that correlation for sure.
Okay, thank you. And on that note, remind me of what your budgeted operating margin losses were and what the operating margin losses would be if this change were to be approved.
I'll take that. It's Jen Bertrand. Our budgeted operating loss was 4.9 million that we submitted to GMCB. And if you take the 9-month impact of that 2.3 million in savings, we would net then to 2.6 as still an operating loss.
Got it. Thank you. Okay. I believe I know some of this information, but you did reach out to the Agency of Human Services in connection with this service line reduction. Is that correct?
We did reach out to them after we had an approved project and had worked with our board of directors.
And as of today, you have not had, back up. Can you explain to me the extent of the discussions and interaction with AHS's consideration of this change?
Yeah, they were fairly high level, and it was the recommendation was that we work with the Green Mountain Care Board for review of this project.
And who made that recommendation?
I don't know specifically. Honestly, I've had conversations with several individuals within AHS, so I'm not exactly sure. There was an individual or if it was just what they felt out of their process.
And AHS has leadership responsibilities in connection with transformation for the state through Act 51, Act 167, Act, I think it was 68. And my question to you is that why is it better for your community and the state to have this reviewed and decided now, as opposed to having it go through AHS's transformation planning efforts?
Sure. Yeah. So I at risk of being highly repetitive here, I apologize. But while finances were a piece of the equation, again, it's really in trying to understand how we were going to continue to staff the unit when we had and have fairly low census. So it wasn't led with necessarily transformation in mind, but we certainly wanted to consider how this change in care delivery would impact and support goals that we believe the state of Vermont was looking for all hospitals to engage in.
Right. So my question is more of one of timing, right? So we do have a respiratory illness season approaching, and AHS has not had a chance to review this in connection with its transformation visions and plans. So my question is really limited and tailored to why should this be reviewed and potentially approved now, as opposed to going through the AHS transformation effort project?
To my knowledge, I don't know if this is within the plan, the transformation plan with AHS. I'm not exactly sure what that plan looks like. We have had numerous conversations with them in following up with them. And it appears that this would be a project that is considered hospital optimization and not necessarily transformation. But I don't want to speak for AHS, certainly.
And I'm sorry, I hadn't heard those terms. What is the difference between hospital optimization and transformation?
This is, I think, more in from AHS's perspective, more in line with hospitals responding to cost pressures within the state, and albeit and truthfully, you know, as we're kind of ahead of where AHS was in their design and structure of what regionalization may or may not be.
Okay. This seems like regionalization to me. You're closing a service line or reducing it or transforming it and then having care go to a different place. Why is that not regionalization?
So I would argue that it has those components of regionalization. And again, that was our desire and commitment to the community. One, we want to ensure that all patients have a pathway for care, but we really wanted and still commit to trying to keep as much of that care at Rutland Regional as we can, albeit in different care pathways that we're exploring.
Okay.
So it is not, it's not completely closing all services or care for pediatric patients. We're really looking at this as kind of an innovative redesign of care.
Yep, I understood that. I appreciate that. This might be a follow-up, but some of these service lines lose money, and some of them lose money because either Medicaid doesn't pay well enough. So if you can give us information on the cost of delivering this care versus what Medicaid reimbursements are, so we have a sense of how much of a gap there is on that, that would be beneficial. And then secondary, because we can make a choice. We can make a choice that this needs to be reimbursed better because it's worth it. It's a prioritization question. Maybe the answer is it does need to be regionalized, but I do think it's helpful to understand the finances behind it. And then the corollary to that is the commercial increases. I would like to see the commercial increases that have been applied to this service line over the last few years. And I'll just verbalize my concern. My concern is that we're seeing really, really high prices at many hospitals including at Rutland, MRIs and imaging. And if you're applying all of your commercial price to MRI and imaging and not to this service line, I think it's something that we need to really consider of whether we're putting the money in places where we want to prioritize care.
We can certainly provide you with our rate setting strategy with each budget we presented to you.
That'd be great. And maybe this is a deeper conversation, or maybe it's a conversation for the next one of these, which is, should we really be reducing the service line, or we should be changing how we're reimbursed for that service line?
Hello there,
And that's not
Dr. Meyer. Hi, how are you? There's a junior here.
It sounds like way more fun than this.
Yes, so I appreciate your questions, and I just don't want to lose sight of just the low acuity, low volume in this unit, and being able to continue to staff it. So I don't want to lose sight of that piece of the decision making that this team considered.
Completely understood. This is a myriad of factors that we have to look at. So definitely that's an important consideration. And I do want to publicly recognize that these are really hard decisions for you and your board. I have no doubt they're painful and they're not fun. And we are going to have some really difficult conversations about service lines in this state. And I don't know if any of them are ever going to be really received with open arms. We just don't want to lose service lines. And we're going to have to, at some point, recognize that we don't have the money for all of them. That's not to prejudge this at all. I'm still very much evaluating it, but it is something we're going to grapple with. I have no other questions. Thank you, Ms. Fox and Ms. Bertrand and your team. And I will turn to the HCA for any comments or questions they may have.
Thank you, Mr. Chair, and thank you, Rutland and board. The HCA, great conversation, great questions. The HCA doesn't have any further questions and really wanted to preserve any time that there possibly could be to hear from the community. Thank you.
Appreciate that, Mr. Fisher. I will go ahead and open it up to public comment via raise the hand. Dr. Marifox.
I know. Hello, can you hear me?
Yes, we can.
Excellent, thank you. I really appreciate everyone's time today. I know we're quite a few hours into it right now. And I really appreciate all the thoughtful comments and really the deep thought about this, because I think it's really important that we think deeply about this decision and all the repercussions it will have to our community and the children of our community. I just kind of wanted, because I know this has come up a couple of times, I wanted to kind of give a high level overview of what the unit looks like. I'm a pediatric hospitalist and I also work in the community as a pediatrician. So I have a lot of familiarity with our entire pediatric population here in Rutland and the surrounding area. So we currently have a labor and delivery unit, which has 4 beds and is staffed by labor and delivery nurses. We as pediatricians will attend high-risk deliveries for resuscitations for the newborns. And we also down the hall, so quite a ways away from our labor and delivery unit, we have our women and children's unit, which I believe has 12 beds total, 5 of which are pediatric beds, but in reality, there's 4 rooms. One of those rooms is a double bed, but is never used as a double bed. So we say 5 beds, but I'd say in day-to-day practice, we have 4 pediatric beds. The rest of the rooms on pediatrics or the women and children's unit is for postpartum recovery, any other on-service needs, so like gynecologic services recoveries from that period. And then we periodically have taken off-service patients. So off-service would be patients from other services, from surgical or for urology who required an inpatient stay. We also have our sick newborn nursery on our women and children's unit. So that is again separate from labor and delivery, where any baby who required resuscitation beyond the first 10-20 minutes of life would come, and we provide really high level ICU level care in that sick newborn nursery. So we're doing CPAP. If we have an intubated baby, we're keeping them there until we can get transferred to a tertiary care center with a neonatal intensive care unit. And I would say our pediatric nurses, who are wonderful and well-skilled and well-trained and very competent, provide care both for our sick children, also for the babies who are on the postpartum unit, as well as they will come over to the labor and delivery unit, again, down the hall to help us resuscitate any sick babies. So they're skilled and they're covering multiple units, and they, again, will take some off-service patients on days that are slower. In terms of admissions, I would say, and I don't have the numbers, so I apologize. I think we're probably about 50-50 from children that are admitted directly from our office, and 50% are admitted from the ED. I would estimate roughly. We have really comprehensive care because we're also the primary care providers as well as the hospitalists, that we can wrap around our patients and our families really well. So if they need admission, we can admit them directly from their office, but then we can also follow them really closely in the office as well, which I think leads to some of the shorter hospital stays that we're seeing, because we can get them right in the next morning and follow them up. And I anticipate that if some of these sick children were transported to other hospitals, that those stays would actually be longer, because the follow-up wouldn't be quite as easy or comprehensive as we currently have. I know some people from RMC gave some examples of the IV down in the ED, but I would say our nurses and peds work really collaboratively with the nurses down in the ED. And I've just as often seen it go the other way, where they're going down to the ED to place IVs. I think I've made no secret that I disagree with this decision. I think it's unsafe. I think it's poorly thought out. And I think it really does a disservice to all of our children in our community and their families who really depend on us. You know, we're a high needs community. We have a high rate of poverty. We have a high rate of Medicaid children. So that's children at or near the poverty line, who would be excessively burdened by transport to outside hospitals. And I think I would anticipate as the admitting hospitalist that many of these children would get transported. There may be some proportion we can care for in the ED, but I think many of them will require more than that 24 hours stay. I have grave concerns about workforce retention as well. I know this is something that the Green Mountain Care Board is considering. I have heard from nurses, our skilled pediatric nurses, OB providers, as well as other pediatric providers, that this has made them reconsider whether they can continue to practice in this community, which would be a loss, I think. I also wanted to highlight to the committee that part of the staffing issues that we've had over the past summer, and that you've heard about ad nauseum, has been due to our very skilled PD nurses also being on maternity leave. So we've had 5 of our PD nurses take maternity leave since May, which has contributed to some staffing concerns. But again, that is a temporary situation, which has now mostly resolved, and they're back and working, and we're anticipating continuing to work until this decision was made. The pediatricians were kind of caught off guard by this decision. We heard about it the day after the RMC board voted, and we weren't involved at all in the plan to redesign pediatric care in our community. There had been a plan in place, and I don't know that this was brought up at any point, to combine the labor and delivery floor and the pediatric floor. There are architectural drawings done. We were on the committee for this. The plan was to help with some of those staffing challenges by combining the 2 units to make our staffing more flexible. And I would question what happened to that plan, because as far as we were concerned, that was the plan in place and there were funds budgeted for that. And I don't think that was presented to the committee as an option.
Reducing number of beds.
We also would be more than willing to work with RMC on ways to either increase reimbursements, either by optimizing our billing or reducing expenses by some of that flexible staffing models. But again, we weren't part of the decision. I have concerns about the cost of transport. Transport is really challenging. It is really hard to get rigs for sick children. And I think it will be even harder to get transport for slightly less sick children, those sort of medium acuity patients who we can care for currently. I think we are creating problems and creating costs for both the system and the families when we have the ability to do it here and now. Thank you.
So I'm getting a few messages that people need a quick 2-minute break. Wesley, sorry, were you trying to chime in?
I apologize. Yes, that's exactly what I need, because I need to get my backup line in. It's about to time out here. So
Yeah, we've gone a little long. So what, Wesley, is 5 minutes enough for you?
2 minutes is enough.
2 minutes. Okay, we'll make it 3. So we'll come back at 4:43, and thank you for the commenters just to wait 3 minutes. Thanks.
Thank you.
Wesley, are you all set?
I am. We're all good to go. We're on the record.
Great. Great. Thank you so much. Okay, we'll resume public comment. Kayleen Chapin, I think you were next. Kayleen? Okay, we'll go down the line. Stephen Casarino? Sorry, your audio's. Okay, try one more time and then I can come back to you maybe if it doesn't work. Nope. Okay. Stay on. We can come back. Amy Fenning.
Hi, thank you. I'm a pediatric hospitalist here in Rutland, and I have a unique position. Can you hear me?
Yes.
Can you guys hear me?
Yeah.
Yeah.
Perfectly fine.
Um,
Yep.
No.
Okay.
No, you sound great. Please go ahead. You're good.
They can hear. They're nodding.
You can hear me. Okay. My name is Amy Fenning. I'm a peds hospitalist nurse practitioner here at Rutland Regional, and I have a unique position because I also for 20 plus years was a staff nurse and nurse educator and nurse manager of the inpatient women and children's unit. So I have a perspective that many people don't have now that I'm on APRN. I just wanted to talk to a couple of points and follow with Dr. Mary Fox, very thoughtful and pointed remarks. First of all, we keep hearing repeatedly that the emergency room sees about 3,000 pediatric patients a year. And I have to, with all respect to the ED, they do a great job with the kids. And I want you to understand that as the 6 pediatric hospitalists that see children in our community, we see approximately about 18,000 pediatric patients a year. So that puts us as the top experts in this field. And having been left out of this decision and not collaborating with the hospital until approximately 3 weeks ago when the pediatric care committee was formed, there's a lot of moving parts that weren't considered as far as the emotional components and the clinical components of taking care of children. And we're starting to touch on that a little bit since we've gotten into these topics with you guys, but there's a lot of things that haven't been considered as far as what will happen to our community and the trickle-down effects of closing an inpatient pediatric department in a state that has essentially a desert for pediatric care now. A couple more things. Dr. Merman pointed out many discrepancies as far as financials go. And there were, I'm not here to talk about financials and I'm not here to say what's right and what's wrong, but some of the things that we need to understand and that you touched upon initially is that there are more expenses that will be associated with these stays because they're not going to be an inpatient stay here at Rutland Regional. And you touched upon that. And I just wanted to reiterate the ER charges where we avoid that now when we're seeing a patient in our exam room in our office. We determine as clinical champions that they need to be admitted to the hospital for a higher level of care. And we avoid the ER, avoid wait times, avoid a charge for the patients and the families, put them in a calm and collaborative setting where they can heal. And to Dr. Mary Fox's point, we can see them right after the office. We can see them the next day in rounds and we can follow them through. It's just a seamless transition where families can stay in their community and we can take care of them with excellent skill. And then in response to the ER saying that they have staff that has been available for an influx as we come into our respiratory season. I'm certain that's true. I'm certain that they can influx their staff. But currently, they spoke to today using the float pool. The float pool staff nurses are currently not allowed to take care of children on the Women and Children's Unit because they don't have the skill. My question to Rutland Regional is, how can those staff members take care of children if they're just in the emergency department? If they can't take care of them in an inpatient unit in the same hospital because they lack the skill, how can they take care of them in the ED in an outpatient setting? I'm unsure of that. And Dr. Davis and Sheena may have the answer to that. That's something that I would like to know a little bit more about. To Kelly Watson's point, she talked about speaking to, and I'm certain she did, spoke to Porter and Glens Falls about their ED keeping children or transporting them because they no longer have inpatient units. But remember, Porter has an affiliation with UVM. Glens Falls has an affiliation with Albany. We have an affiliation with nobody. So we are not a priority. And these transport agreements that are there, and they certainly are there, it was already pointed out by the board in bold statements. It says they are not obligated to come. They have to have the bed, they have to have the staff, they have to have the rig. And if they don't, then we wait and we sit and we wait. And as you can see from the slides that were presented by Rutland Regional today, there's a photograph of a trauma room that essentially is staged with a teddy bear and a coloring book and a red wagon. Does not make it a pediatric room. It truly isn't developmentally appropriate. That is not appropriate for little kids. And of course, pediatrics and the ED are specialties, and the ED, again, does a great job. However, when we talk about pediatric care in the emergency department, their job, and they do it well, is rapid assessment of critical illness or trauma. It's not about developmentally appropriate care where children can heal. And putting a child on a stretcher with a teddy bear in a trauma room is terrifying. It is terrifying when they have an acute illness, but even more terrifying is the fact that they have to stay there for up to 24 hours because we don't have a place to put them. And if you think about what's happening from just a physical standpoint, a physical safety standpoint in the emergency room, it is an overall locked unit, meaning there's security at the door when you come through. But just knowing the ED as is now, that trauma room they took a picture of has an open door right to the ambulance bay, which goes directly into a parking lot. And people there are busy. The staff are busy taking care of seriously ill people. Little kids can wander out in the blink of an eye. And on a unit like the Women and Children's Unit, anybody 10 and under has a bracelet on. They have an alarm that keeps them safe. If they go near an exit door, it alarms. There's none of that down in the ER. It's kind of scary. It's not a therapeutic environment for children to heal. And for many, many, many reasons, elopement being one of them, that's a concern. There's people around that are in crisis, that are angry, that are drugged, that are doing things that are inappropriate for little children to see. So as a pediatric APRN and hospitalist, I think that it's a very inappropriate plan. And I'd love to collaborate with the hospital and come up with a better way. Certainly, I would love to see us have a smaller scaled down unit that has 1 or 2 beds attached to labor and delivery, that we could keep children that are on high flow O2 that are very difficult to transport, and keep families in the community. Thank you for hearing my comments.
Thank you. And thank you for taking the time to stay and wait and to make the comments. I'll go to Dylan Marifox.
Hi, sorry about that. So you already met my wife, Dr. Mary Fox. She's pretty awesome. What I'm kind of approaching this from is the other side. So my work has been traditionally with older folks with, I'm on a board for a nursing home, the Gill Oddfellow Home down in Ludlow. So one of the things, and I know this sounds like a kind of an offshoot, but one of the things that interested me about the narrative was the discussion about taking care of our older populations. And I wonder, because we haven't heard from RRMC, what the plan is to use those beds. Was there a plan for those beds? And is there any discussion about how that's going to impact nursing homes that are already full up, right? So if they're planning on doing, say, orthopedic work, if those are, I heard a recent commercial. There seems to be some sort of like advertising push for that right now, and I wonder if that's like where this was headed, because the reimbursements are so much higher for orthopedics and for skilled nursing than they are for children. It seems to me that we haven't discussed like why this change is happening and why the change was created so suddenly. I know that our RMC recently hired a new orthopedic surgeon. So like, did this plan change, and did it happen suddenly because there were new resources? It just seems like, as a board member, seeing the lack of due diligence and the kind of financial issues that have been highlighted, I can't believe it made it to this stage so quickly without being vetted thoroughly or without looking at alternative like revenue sources. Closing a unit is it's a big thing. And I wonder why that step was made. Oops.
Great. Thank you for your comment, Mr. Mayor Fox. Sarah Christiana.
Is it on?
It
Yes.
is.
Okay. Hi, I'm Sarah Christiana, as you said. I am a primary care FMP at Community Health. As of very recently, I worked at the hospital for 5 years as an RN. And I'm also the proud mom of an asthmatic 2-year-old. And I myself am a former sick kid. I have grown up with Crohn's disease and asthma. I have been taken care of by almost all of the current pediatricians in our community. And now they're taking care of my son, Luca. And I just want to speak mostly as, less professionally and more personally. It is invaluable to know the physicians and nurse practitioners taking care of your child. Luca's been in the ED a few times. We have also been admitted to the Women and Children's Unit. My husband and I had a newborn foster baby kind of put into our laps a few years ago, and we were admitted with him. And I just can't express the care that they give in that unit and the support, not only for children, but for their parents. Not that the emergency department isn't fantastic. I have so many friends and colleagues who work there and provide amazing care, but it's the time factor. They don't have the time to, for example, we were inpatient with our foster baby. We hadn't slept, probably either of us, in 3 days. We had never had a newborn. We were 22. Like I said, it was an emergent situation where this baby got put in our laps. Those nurses held the baby just so we could sleep for a few hours. And it's another huge, I lost my words. Another huge benefit of inpatient stays in this community is that, and as the hospital said, oftentimes they're only a day or two. And really that's because the pediatricians at Community Health follow up with those children, usually within 24 hours. I think both times we've been in the emergency department with Luca for respiratory issues, we saw Amy Fenning or, gosh, I can't remember, one of the docs, baby Dr. Baker. And then within 24 hours, guess what? We were seeing Amy Fenning again in the office. So that congruency of care is just so valuable to people. And although sure, we would have been fine if we had to transport to UVM or Dartmouth, our family could make it work because we're very fortunate. and we have good transportation, and our parents live here. There are so many families in this community. And I know now I'm taking care of them. I'm taking care of their kids. I'm taking care of their parents and their grandparents. We have so many families living below the poverty line here. They don't have transportation to their doctor's appointments. They don't have transportation to get to these hospitals. They have multiple children. They can't miss work. They don't have paid time off. And it's very scary. It's very scary as a mom. It's very scary as a provider. So thank you for taking the time. And I know this has been a long meeting, but I really do appreciate you allowing time for us to give our comments.
And we for taking the time to give them. Stephen Wood.
Yes, hi. Can you hear me okay?
Yes, we can.
Great. I'm a hospitalist at Rutland Regional and currently the chief of pediatrics. Just wanted to reiterate what has been said a few times, and I really appreciate the careful questions from the board. But looking back over the public comments, one theme that really comes out is just as the reimagining of pediatrics at Rutland Regional is really an inpatient closure. And really that leaves the central Vermont as pretty much a desert of hospitalizing children, all the way on the flanks of Vermont from south of Manchester all the way to Middlebury. And this is really makes an intolerable burden for so many families. And it goes on the assumption that our tertiary centers can simply absorb the kids that we are not able to take here. So appreciate your careful questions and listening to us. Thank you.
Thank you. Robert Knox.
Hi, I'm Robert Knox. I'm a respiratory therapist. I've been at Rutland Regional for a little over 25 years now. So I've had the luxury and or curse of really the luxury of working everywhere in the hospital. So I've been in the ED. I've also been in pediatrics, the birthing center. So I get to see both sides. And unfortunately, what was presented earlier was definitely misleading on how the PD nurses were presented. I felt that some of the presentation by the ED, staff, the director, were inappropriate. Our PD nurses are very competent, and they have actually, our ED nurses have actually asked PD nurses to go down to help with rather IVs or to take care of a patient that may have been being held down there to be transported. And as far as the safety of our PD patients in the ED, there again, being down there, I've had, been staying with our PD patients if we have them on high flow, what have you, where I've actually had to close doors because you do have patients screaming outside the doors. So some of the safety issues that they're trying to present as the ED being safe for our PD patients is misleading as well. Because there again, I've witnessed what can happen in the ED and, how it affects our patients, the anxiety that it creates for our pediatric patient, the anxiety our family is going through. So really it's a necessity, hopefully, that, we keep our pediatric unit open. And thank you for letting me talk.
Of course. Thank you very much. Kayleen Chapin.
Okay, is it working this time?
It is.
Okay. Hi, thank you. My name is Kayleen Chapin, and I have spoken before, but I feel that it is dire that a community member and a mother that is actively on the unit often has a word. One of the biggest arguments that we've seen today is the lack of the pediatric volume. And sorry, go out. Sorry.
Right on cue. Was that planted?
I know. Yeah, no. So anyway, it was the lack of the pediatric volume, and my family personally has been in the ED many times, and it's really unfortunate to say this. I don't want to say anything negative about the ED staff, but there have been many times where we have been seen by the ED staff, and a pediatrician was never consulted. There was one time where my son, even though he's crying very well right now. He does have a rare lung disease and is often in need of respiratory support. He was seen and was just blown up like a balloon for reasons unknown, as he also has autoimmune deficiencies. But unfortunately, a pediatrician was never called, and we were about to be discharged until a very lovely nurse within the unit was like, "Are you sure you agree with this?" And we were crying. We said, "Absolutely not." And as soon as the pediatrician was aware, we were admitted, and the care was absolutely wonderful. So sorry. So there's been other times where the pediatrician hasn't even been consulted, and the one thing that worries me about that is that the data could be really inaccurate. How often have these patients or children been in the ER and been sent home without a pediatrician consult? That might alter how many children might have actually been admitted. It hasn't happened many times to us. Let's see. So the other problem that we have faced specifically, and we are so beyond grateful for the physicians and the nursing staff of the WACU, or the Women's and Children's Unit, because without them, my son wouldn't be alive right now. They had tried to get us transferred over 8 times, maybe even 9, to UVM, and they wouldn't take us. They kept denying us for multiple different reasons, and the wonderful staff at Rutland WACU just really advocated for my son. They kept pushing until finally, about the 11th admission, they finally took us. And with after a CT that they ended up discharging us for and then readmitting us for, we were immediately shipped to Boston. So I do believe that getting rid of this Women's and Children's Unit would really create a safety issue with our children in this community. Just because, especially like you guys have mentioned before, winter is coming and flu is coming and all these respiratory viruses, and these other hospitals, they fill up fast, and that may be the reasons we were denied before. But if a child with a rare lung disease who is very vulnerable isn't admitted, it makes me very fearful for the other children that may be held in the ER for longer periods, just to not even be considered if their symptoms aren't as strong. And the other thing I wanted to touch on was I do agree with some of the other comments that the ED is just not sustainable for long-term care for pediatrics. Women's and children's, their rooms are designed for the whole family in mind. I can't tell you how many times I've been there with my son all day, and I don't want to say anything wrong or negative to the ED staff because I know they work very hard and they're wonderful people. But there's times that they couldn't get away, and I went 8 hours without a glass of water or without a restroom break, even just a second to leave my son, which as soon as on the times that we were admitted, the staff on the Women's and Children's they just took over, and they loved on my son, and they said, well, what can we do for you? Because I couldn't leave him there. I had to be admitted with him. And I know that's not always the case, but oftentimes there's also children that are admitted with no guardians or no parents with them, and it takes more than one nurse to take care of those children. I don't see how that's going to be sustainable in a very already busy, hectic ER. And then I just wanted to thank everybody and thank the board for taking the time and the conversations and the questions that you have been asking. This is a really big matter to us community members in the Rutland region and outside of Rutland. We really wanted more of a say in this conversation. I and more than 3,000 other community members truly believe that this proposal really goes against a lot of what Act 68 has to say, and in many ways, and it's really nothing short of a very large issue and problem that our community does not want to see happen.
Great, thank you very much for coming. Thanks, Ms. Chapin. We appreciate your comments today and for taking the time. David Schneider.
There I am. You hear me all right?
Yes.
Well, good. Okay. I'm the old pediatrician. stepped away from practice a few years ago. Spend most of my time when it's in pediatric work trying to advocate as much as I possibly can. I'm actually would like to point out something that has nothing to do with medicine because, well, peripherally it does, because you're hearing from the best of the best. Whenever I listen to the pediatrician speak, it just leaves me so gratified to know where I left. You know, these are the people who I left the practice to, and they just keep getting better and smarter, better and smarter. And as you hear from them, it's all about the children. It's all about the children. They are right now taking on 2 jobs. They're working full-time pediatricians, or they're trying to save a unit. And I do hope everybody appreciates what they're going through right now. One other point from a medical perspective is the way that transports are being talked about. They're being talked about like Uber rides to the Basin Harbor Club. These are serious, very, very time-consuming things, incredibly scary to children. There is no such thing as a 2-hour transport. If you're lucky, there's a 5-hour transport. The time it takes, most pediatric transports means that either Dartmouth or UVM is coming on down to get the child. It takes a while to get a transport team together before they can even make the 2-hour drive down or across. And that's if they don't have a prioritized transport. And we're talking lowest priority transports. And the vast majority will be during illness season when children are sick in Rutland, they're sick everywhere else, and they're going to need transports. So I would just like to point out that they are incredibly serious, very time consuming, beyond expensive parts of medical care. And we do everything we can to avoid them. An unnecessary transfer is unethical, it's dangerous, it goes against anything any pediatrician ever practiced for. So I would like to point out about Rutland. The presentation about Rutland has been like it's a dying, aging community without any acknowledgement of our new mayor and all the investment that is going into Rutland right now, and the investment that's taking place to try to grow this town, and actually is succeeding. If you look at today's Rutland Herald, and I'm happy to send a copy for the public record, Mayor Donges, I'm sorry, I have a hard time pronouncing his last name, wrote a beautiful piece, the second of 3 parts on growing Rutland and a stronger voice. Just a small part of his op-ed, he says, my administration picked a clear focus, growth. And just then he goes on to talk about new private investment instead of chasing it away, inviting it, that they brought in more than $8 million in new housing projects so far, with long-term goal of building around 1,000 new housing units in our city. Okay, new landlords are stepping up. New home buyers are committing to Rutland. New businesses are opening their doors downtown. This is not a, this is one we need to be looking forward to, not doing something irreversible and killing something that's so necessary like a pediatric unit. Representative Holmes, Jessica Holmes' point, why aren't we looking at actually growing the unit instead of shrinking it? I think with some thoughtful consideration, that should be a real discussion. You know, to do something in a matter of months behind the experts' back and then put it into play over a matter of weeks it's just insanity. It goes against anything any compassionate physician would ever be comfortable with doing. This is just my thought about that. So, well, thank you very much. And I'll hand it off to the next person.
Great, thanks. I'm going to take about like 10, 15 more minutes because people have childcare duties and things here, and we're quite a bit over. So just be mindful of the other commenters. We've got a few left, but Mila Lindroos.
Hi, can you all hear me all right?
Perfectly, yep.
I am one of the emergency nurses. I'm also a PD high tech and hospice nurse in the community. And so I just have to say, I'm alarmed to hear these discrepancies in numbers when at the same time I'm hearing that on the side of pediatrics, there's a lot of flexibility that would be very happily considered. I think that making the most extreme choice, cutting, a specialty entirely, I don't know how that's the most reasonable choice here. We're creating a care desert, a pediatric care desert, basically spanning 4 hours in good weather, which we know, 6 months of the year we don't have here. And as for the way the WACU nurses have been characterized, I'm really ashamed. I'm ashamed of how our staff has spoken of them because I work with those members of our community. And I know that more often than not, it's my emergency department that's reaching out to them for help. I love my job. If you ask anybody, they will hear that, I particularly love taking care of pediatric patients. Um, but taking care of pediatric patients in the emergency department is all about prioritization. So if I have a stroke patient, if I have a chest pain patient, their needs are going to be dropped down. I don't want it to be that way, but that's the nature of an emergency department. They're going to miss those Q2 or 4 hour nebs. They're going to miss the scheduled medications. I will always be doing my best, but the reality of the situation is that any patient boarding, I realize that we're saying they are not inpatient, but it's essentially boarding a patient. And we know that one, the cost of boarding a patient is roughly double of having them be in an inpatient unit. And that's according to the American College of Emergency Physicians and the Annals of Emergency Medicine. And we also know, I'm just going to quote it right here. I think Becker's Hospital Review puts it best. It's not only more expensive for that inpatient to be boarding in the ED, but it's also less equitable by rote numbers. That's what we're accepting for our kids. And then let's talk about the adults, because these transfers are impossible. They are so difficult to make work. And we try really hard. I will say our emergency staff work their tails off. But if we send one of these kids who's pretty much stable, who we should have been able to keep, and now that rig is 2 hours away, and somebody comes in with a stroke, with a heart attack, they're now waiting hours before they get that care. And they can't get that tissue back. They can't get that brain tissue back, that personhood. They might never be able to walk up a set of stairs unaided again because they've lost that heart tissue that they should have been able to have restored with timely transport. We're accepting a huge amount of risk and a huge amount of harm to our community. And I'll just say, as a mother of a 3-year-old, I wouldn't take my daughter if I thought she might need admission. I would bypass Rutland. And I at least have the expertise, I think, to know when that is a safe choice to make a 2-hour drive. I think other people will make that choice and it will be significantly less safe. And I think we're going to see some terrible outcomes. And I just hope and pray that you guys are hearing this and hearing how much every person involved in this who is hands-on is saying this is a dangerous choice and there are better alternatives. Thank you so much for your time.
Thank you. Appreciate it. Appreciate all the providers providing their input. Olivia Lawson.
Hi, my name is Olivia Lawson. I am a mother in our community and also, fortunately for now, one of the LNAs on the Women's and Children's Unit. I do have a really big concern about our PD patients being held in the ED. One of my roles, a significant amount of time, is to spend time with our pediatric patients, caring for them on, getting them the snacks that they need and making sure that they're being checked on. They're not, their parents not falling asleep with them in the bed in an unsafe situation. They aren't standing, all these things that kids get into and do. And they need a lot more care than an adult patient. They need frequent check-ins. We are looking into our patients' rooms at least every hour, if not much more frequently than that. And from experience as a parent with my kids in the ED, I've gone 2 or 3 hours before without seeing anybody. I really worry about our babies downstairs and that they're not going to get those check-ins. I also worry about the amount of education that we provide our patients, our failure to thrive kiddos and our kiddos that their situations may be preventable with some education. I don't think the ED has the resources to provide as much education. Sometimes that takes 2 hours to provide all the education to our parents that they need to discharge their baby home safely. And there's just not the resources in the emergency department to do that for our babies. Yeah, I don't see how that's going to be a sustainable thing for the emergency department nurses or doctors to do with the kids downstairs. And that really worries me, that they're going to be discharged prematurely without that education, or that they're going to sit in the ED without those check-ins, and that could result in bad outcomes for our kiddos. That's all I have to say.
Great, thank you. I think I have 2 hands left. Janet Casarino.
Can you hear me this time?
We can, you got it.
Oh, perfect. Okay. So I'm Janet Casarino. I'm a mom in Rutland of 6 children, and we have had many stays at Rutland Regional. My youngest has a lot of lung issues. We have done the gamut. We've had stays in the emergency department. We've gone to the emergency department and then we're admitted. We were direct admitted from pediatrics, and we've been transferred to other hospitals. I want to reiterate what some of the providers have said from a parent perspective. The fact that we can go to our pediatric office and they can send us over to the hospital, which is 2 seconds down the road, and be directly admitted is a huge time saver. The staff in the WACU know, they know us. We know the nurses. They know my daughter's history. They know how to take care of us. And then our primary care provider, who you heard from earlier, Dr. Wood, he's on top of things. Amy Fenning, who you also heard from, Dr. Mary Fox, Mr. Knox, who is the respiratory therapist. All of these people I know personally because we've interacted because of my daughter's care. And shipping her off to UVM or to Dartmouth, or when we couldn't get to either of those places and they couldn't get transport for us, they had to get a flight nurse crew to take us to Albany, which was the closest place and the fastest way that they could get us there. To say that we're creating a care desert for children is an understatement. And my daughter now falls into the range between, she's past the neonatal care because she's 3 years old. She's not old enough for the adolescent care that they're talking about. So for her inpatient stays, which I believe she's had 6 of them now at Rutland Regional, they were all between 3 and 5 days. So she is one of those patients that would either have to stay in the emergency department or she would be shipped off to another hospital, which is incredibly burdensome for a family like ours, where I'm a stay-at-home mom with 5 other children to look after. How do you handle that care when now you're 2 hours away? And I don't think that the people who are in charge of making these decisions are thinking through the situations that they're putting families in. I like the idea that Dr. Mary Fox had brought up, and I wish it would be explored further. I understand cutting costs. It makes sense. We do have the lowest birth rate in the country. We have an aging population. I get all of those things, but people are more than data points and more than metrics and algorithms. And the fact that we are, sacrificing care for our children without considering the idea that Dr. Mary Fox brought up of, possibly consolidating the birthing center with the WACU and having some kind of cross care between those two units, I think that makes a lot of sense. And I'm wondering why this wasn't explored further and why other people were not considered on the committee or to create a bigger committee to discuss these issues. Having cross-trained staff that can care for mothers and infants postpartum, but could also care for young children in the pediatric unit, I think is essential to care in Rutland. And then finally, just alluding to or going back to talk about the transfers, I know many people have said how difficult it is to get a transfer. And I experienced that with my own children when we had to fly to Albany on a helicopter because that was the only way they could get us anywhere. But I've also experienced it with myself recently. I had to be transferred from Rutland in September for some maternal fetal medicine care that I received at Dartmouth. And it took half a day to get me, who was bleeding, near hemorrhage, to Dartmouth for care. And that was an emergent situation. So if my daughter, who's on high flow, needs a respiratory therapist, needs to get admitted to the hospital for several days of respiratory care, where is she going to fall when a patient like me who needed emergent care couldn't get transportation? And then last thing is the emergency department care. I know several people have touched on this, and I think it's critical to know, we've been in the emergency department with my daughter overnight at times because there was no bed available in the women and children's unit. And I slept on the floor of the emergency room that my daughter was in because there's nowhere for the parents to be. There's a chair. And it's not a reclining chair, it's just a chair. So I slept on the floor with my coat as a pillow while trying to care for an incredibly sick daughter who is on high flow. And I think all of these things need to be considered: the comfort level of the children and the families, the coordination of transfers, but also the level of care that you're going to receive in the emergency department. While they're phenomenal, is not the level of care you receive from specialists in pediatrics. So that's all I wanted to say. I hope I got it all in. Thank you so much for your time.
Thank you, Ms. Casarino. Anna McCloy?
Can you hear me?
Yes.
You can hear me okay? Yes. I'm Anna McCloy. I'm one of the pediatricians here in Rutland. I am both a pediatric hospitalist and an outpatient primary care doctor for kids. I just wanted to say thank you, Chair Foster, and to the Green Mountain Care Board for your time and attention to this very important discussion today. I would like to point out that RRMC's full submission PowerPoint presentation is polished, but you will find the greatest honesty regarding this situation in the outpouring of articulate and nuanced public comments from a broad range of community members, including Rutland Regional's staff, and the many voices you've heard from today. All of our lives will be very changed by this proposal. I know you will afford the facts and the sentiments submitted from the public comment the same level of attention and trust that you afforded the information and data provided by Rutland Regional. We're really grateful for the critical and objective review of all of the angles of this situation. Rutland commented many times on our low acuity and our low acuity and our short length of stay. So I just wanted to quickly hit on those. I know we've talked about them a number of times, but the low acuity patients that they are referring to are what is appropriate for a small community hospital. It would be inappropriate for us to retain higher, more critically ill patients at this hospital. And so we do not argue that our acuity should be higher in any way. We should be caring for this middle acuity patient that has been referenced a number of times. And then regarding the short length of stay, this has been hit on a couple of times too. Children don't have the same physiology as adults. They are not small adults. They get sick quicker. They recover quicker, especially with prompt, safe, and appropriate care in the right setting in a therapeutic environment. One relatively unique characteristic of our pediatric hospitalist group that we've hit on is that we are also the pediatric primary care doctors in the community. And so our patients flow between our clinic and our inpatient unit back and forth as efficiently as possible. And we, as often as possible, attempt to avoid the emergency room because it is redundant expense and not the ideal place for kids. So we would consider this expeditious, resource conscious care that should be celebrated, but instead it really feels like this is being used against us. The pediatric care providers have and always will continue to be advocates for the children of Rutland County and beyond. Our catchment area extends well beyond Rutland County. The proposed cost savings is not worth the risk and the disadvantage to our community's children. The loss of the inpatient pediatric service in Rutland will have devastating effects locally and statewide. It will erode trust in Rutland Regional Medical Center. It will change access and quality of healthcare for residents in our area for generations. This is not a service that we will easily get back if it is disbanded. Again, I really appreciate your time. Thanks for staying over time for all of the comments.
Of course, thanks very much, Dr. McCloy. And the last public comment is anonymous. So we all wait with bated breath. Anonymous unknown user, you have the floor.
Is that me? Am I anonymous?
Well, not anymore. I heard your voice.
I am so sorry. I had difficulty logging in. This is Representative Alyssa Black. I just wanted to end by saying that I really appreciate Chair Foster, the entire board. I know that, you know, these decisions weigh on you, and I know how difficult they are to make. And I can appreciate all the public comment, you know, as a mother who has laid next to my child in a hospital room. I know what that feels like. And I know that these are very, very personal issues to people. And these are really hard decisions to make. They're personal decisions, just like $50,000 premiums are for a family. And I just want to say that I truly appreciate the board and the time and consideration that you're putting into this. And I know that you will make the best decision that is in the interest of all Vermonters. So thank you.
Thank you, Chair Black, for making the time and attending the hearings. You cover so many, and I really appreciate it. Oh, sorry.
Sorry. I didn't know how to raise my hand because I'm just like on my phone, like as a phone call, and I just wanted to make a comment.
Please.
Okay, so I'm a mom of 3 boys. My youngest has been a very sick child, like some of the other moms that I've heard. I could tell you there was a dozen times we went down to the ED, and there was a time that he was admitted, and the only reason why we got discharged early was because there was a pediatrician that we could see that next day. And if we couldn't have gotten into the pediatric office, he would have had to stay longer. And there was a handful of other times where he was down in the ED, and the ED staff is wonderful, but again, there's times where they can't check on you. And I could tell you there's probably a handful of times that he should have been admitted, but they never got to see a pediatric doctor. It was just a doctor or PA telling us that, you know, just follow up with your primary and he's fine, but he's running, you know, 105 fever, and I struggle to get their fever down. I work in the hospital also. I know like what to do to try to get a fever down, but sometimes it's hard. And
I think you were cut off. Okay. Any other public comment at this time? All right. Well, many thanks to our Director of Policy, Elena Barabee, and Hillary Watson, and Mark Hengsler for putting together this policy and preparing the board for today's hearing. And to my board members, I thought it was a really productive hearing, and I appreciate your questions. And Rutland, thank you as well for a very thorough submission and handling all of our questions to help us. And many, many, many thanks to the public commenters. And I will ask if there's any new or old business for the board. Whatever it is. And with that, I will move that we adjourn.
Second.
All in favor, say aye.
Bye.
Aye. And